All right. Hello, guys. Welcome back to our YouTube channel. I am so excited tonight that we have some special guests who are coming on to talk to us. We've had a couple of people ask us about diabetes and advances in technology. And so I've got some very interesting people who are going to come. These are folks that I've known for a while. They come into our office, they work with our patients. They're actually like a part of our family in our office. So they're going to talk with us about some advances in diabetes, some technology, and we're just going to sit and chat for a little bit. So I have with me today Jill, who is one of the pump trainers that works for Medtronics. So Jill, let's go ahead and get you on the scene here. And Todd, both of them came on at the same time. All right, so Jill and Todd, they work for Medtronic Diabetes, the diabetes division, and they are trainers. They are pump specialists and experts. Thank you guys for joining us tonight. Well, so let's talk a little bit about diabetes. So 34.2 million people in the country with diabetes, 1.6 million type 1s, the rest type 2s, 88 million people who are pre-diabetic. So we're talking, if we put all of those together, over 100,000 people, 100 million people, of people
Right.
who are diabetic, at risk for diabetes. um, what does that number say to us?
It says there's a huge need and there's so much of it that we can probably do some things about on the front end, just with education and things like that, and helping people to understand what causes different things. And I do believe that there's a strong genetic predisposition toward insulin resistance and those things. I think sometimes patients get kind of beat up on feeling like it's their fault that they have type 2 diabetes and stuff like that. But just to help educate patients about the cause of these things and everything else. And we do need to do a better job on exercise and eating well and those things. But there's just a lot about how the body works that I think patients need to know.
Right.
Yeah,
Now,
absolutely.
I've always thought about, and we're using the word pandemic for COVID-19. Um, but I saw a statistic somewhere that there are right now probably about between 400 million and 600 million people around the world with diabetes.
Yeah.
That's a huge number,
Yeah.
and it just continues to get more and more. I think they're telling me that by the year, it's supposed to be 2025, I believe, that 30% of everyone in every state in the United States is going to be obese. And we know
Wow.
that's a huge driving force behind type 2 diabetes. As you talk to patients and you interact with them, what is their kind of state of mind for those who are just diagnosed, those who have been diagnosed that are coming to you for the first time? What are they saying to you about how they feel in this huge, um, I'm not going to say the word pandemic, but this huge issue that we're
Yeah,
having?
sure, definitely. It's extremely overwhelming. Majority of the patients that I see, brand new diagnosed, they were experiencing symptoms for many years, and it just like a light bulb came on, or they had family members that had diabetes, or it's so common, unfortunately, but it is something that most people are aware of, yet they really don't necessarily know what to look for or what even to do about it. It's just such a stereotype, I feel like, that they just think, well, in order to have diabetes, type 2 diabetes, or really even just diabetes, most people don't even know how to differentiate the types. It's just that you have to be overweight and eat a lot of candy, but it's so much more than that. And so many people feel ashamed, and I know you, doctor, would completely understand this, that when you're meeting with a patient who has diabetes, there's so many other things that are playing into it. And a lot of that is even depression and just a sense of the patient just feeling defeated, and that at this point that they feel like there's just no hope and they sort of want to give up. But I'm just so thankful I have the opportunity to encourage them, as someone who lives with type 1 as well as has a father with type 2. But just to be able to say, no, that's not the case, and you are in the right place now, and you can get back on track, and there's so much out there to just empower our patients to do well.
Wow.
And I
Wow.
would echo that, Doc. Just I think I told you a couple of weeks ago that a patient of ours that had been using some other educators and folks with Medtronic in another city, in another state, and they had moved over here to Huntsville. And I recommended them coming to you because I knew that they would get the truth. There really is a lot of them, to Jill's point, feel completely like doomed to a few things, and it's the big three. The three apathies. Retinopathy, neuropathy, and nephropathy, and they feel like that's going to happen because they've seen it happen in other people with diabetes. And to know that there really is tremendous data in the two big landmark trials, UKPDS and DCCT, to tell us no. I mean, we know that we can arrest this in its tracks. We can stop this and really prevent, in many cases, any of those long-term complications at the microvascular level from occurring. And so when a patient realizes that that this is something that doesn't have to beat them, I think that
Right.
they have some hope. And that's really a huge part of the time that we like to take with the patients, is to give them a lot of the background about diabetes, give them some of these numbers, a 7A1C, a 154 average blood sugar, those so that they kind of know this is doable. This is not some
Mhm.
crazy unattainable thing to be able to live a normal life. Your normal is just a little bit different from everybody else's, but so is everybody else's. Mine and your
Yeah.
normal is not like Jill's normal. So I think that's something that can encourage folks.
Right, right. Now,
Absolutely.
Jill, you mentioned the word there, shame. And
Mhm.
so I'm going to share something with you guys and with everybody, I guess now, that I've not shared with a lot of people before. So a lot of people know that I'm diabetic. I'm a type 2 diabetic, and I've been diabetic for years. And I share that kind of readily now. But there was a time when I didn't share that
Mhm.
because I had bought into the shame of type 2 diabetes. And
Mhm.
in fact, I remember a story, a young man that I was taking care of, probably 15 or so, who was struggling with his diabetes. And we were in the room with him and his mom and dad. And he said, you guys don't understand, because he
Mhm.
was trying to share with us how he felt. And he just
Yeah.
wasn't getting through to mom, dad, and he thought not to me. And he turned to me and he said, you guys don't understand. He said, Dr. Woode, are you diabetic? And I said, no.
Wow.
I said, no. Because the, even though I was his physician, the shame of being a type 2 was so intense.
Mhm.
Yeah.
So they went away, and that stuck with me. And a couple of weeks ago, a couple of weeks later, I called them back and I said to them, "Hey guys, I need to say something to you." And I told them, the story.
Wow.
And the young man turned to his parents and he said, "See, even the doctor doesn't want to be diabetic."
Wow.
Wow.
So there's this thing that we've convinced people of, that
Right.
that it is your fault. And there are people out there that are suffering. They are diabetic. They know the complications, but they don't let people in their families know. Nobody on their job knows. And we've got to kind of break through that to let them know,
Yeah.
like you said, Todd, that there is hope. I mean, there is a way that we kind of get through this. Okay. So thank you
Absolutely.
for mentioning that word, Jill.
Yeah.
Yeah.
One of the things that I've talked with people sitting in the rooms with me. I was with one today, Um, and I try to let them know that there's an obvious component to type 2 and insulin resistance that we haven't figured out yet, because you could take 10 people who are overweight, and there will be a large majority of them who don't develop type 2 diabetes. Right. But then there's another one who does. And so it's obvious that it's not just carrying that, but that some people who do have this predisposition toward insulin resistance, yes, the extra body weight increases that insulin resistance. We know that, but what we don't know is why does it affect some people one way and others another. And it makes you wonder if we're kind of putting, kind of which came first, the chicken or the egg. Maybe some of these people have a predisposition toward insulin resistance that leads to the ease of gaining weight, particularly in the midsection. And that we may have been blaming people for something that is just as a predisposition as a type 1. I think letting people know, forget what you've been told as far as this blaming yourself. What do we do now? And I think that's where having good clinicians like yourself and having technology can really help a lot of those people.
So one of my favorite episodes of Star Trek is this one where the old crew has gone back in time, and Dr. McCoy and the rest of them, they're running through this hospital, and they see this lady that's sitting on a wheelchair, and she's being rolled into get a dialysis catheter. And he asked her, "Oh, what's going on?" And she said, "Oh, I'm going to get dialysis. I'm sick," and I forgot the exact words. And he says to her, "Oh, these barbarians," right? And he goes into his little bag and he pulls out a pill and he hands it to her. And so they go off, and they finish the mission or whatever it is. And as they finish the mission, we see them running back through the hospital trying to escape. And there's the lady, and she has the entire hospital staff around her. And they're wondering, oh, what is this miracle that has happened? Because she no longer has to go to dialysis, and she's healed. Wow. And sometimes I think is diabetes close to that? What do you guys think? Are we close to that?
It's a big question. Closer than we've ever been.
Yeah, I mean, we're definitely moving in the right direction. There were some studies done at UAB, 2 different things, one using a monoclonal antibody and one using a pretty well-known calcium channel blocker, verapamil, that have shown promise that if used together, you could arrest the beta cell destruction. That said, that's still a ways off. From a technological standpoint, I think that we've gotten to a place where we can definitely get people to euglycemic levels, normal blood sugars, and prevent these long-term complications. The Dr. Spock or the Dr. what's his name, McCoy, reversal of all those things. I don't think we've gotten anywhere close to that. But I do think that there is so much energy and intellectual power being thrown at this disease that I have to believe in the coming generations we will see some major breakthroughs on that. Strangely, I personally think that type 1 right now, we have a better shot at finding a cure for it than I do type 2. As far as that's my opinion, just based on having looked at what kind of research is going on in both areas.
Right. Yeah. We were involved in a couple of studies, and one of the things that people have talked about for years is this idea of extending the honeymoon period. And for those of you who don't know, the honeymoon period is typically that year after someone is diagnosed, where their beta cells are really kind of given their last, right? And then we get that beta cell exhaustion. And a lot of times during the honeymoon period, people who were on insulin are able to come off of insulin. Okay. And so how do we prolong that? And you're right, we're not there yet, but we do have some pretty exciting technology. So insulin pumps, we started talking about that. They've gotten much, much smaller. Jill, tell us a little bit about pump technology.
Yeah, so I can show mine right here, but basically you can see that it's definitely smaller than a cell phone, and definitely I love fashion, so I'm able to conceal it if I need to. But I like to at work wear it just for everybody to see, because I want to make sure other patients are comfortable if I have it out, so that they can be comfortable if they have theirs out. We have a colleague that speaks to a lot of our prescribers and education programs, and she'll stuff like 8 pumps in her dress and ask, does anybody think that I have on a pump? And no one would ever know. So I always try to help everybody understand you can make it as known or as unknown as you wish. But currently we have our 770G pump, and so that little blue shield there just indicates that I'm in what's called auto mode, and just allowing my basal insulin to be automated. I will get a little tiny delivery based on what my sensor glucose is, and if it needs to ramp up a little bit, if it's going up, it will, or if it needs to back down a little bit, it will. And it's been life changing for me and for so many of our patients. Another thing I was just telling Dr. Wood about, Todd, before you jumped on, is now being able to see this remotely, so I can better interact with my patients and check up on them and make sure they're doing well, especially onboarding them. Just had a brand new to this system 84-year-old lady doing very well. I'm so proud of her. But from 2 years old to 84 years old, I have patients on both ends of that spectrum, and it's just been really, really wonderful.
That's good.
So, so Jill, you said that you're diabetic. How long have you been on the pump, and what has it done for you compared to therapies that you were on before?
Yeah, so I was diagnosed when I was 10. I'm 36 next month. So for 26 years, I've had diabetes, and I actually started on my pump 2 years into my diagnosis. My physician, he was just my primary care physician, and he actually had type 1 as well. And so he was, of course, very into helping me get on the quickest therapy that I could. So his pump was a Medtronic pump, so that's what he wanted me to be on, and I didn't really know any different. And I'm thankful, because that's what I've been on my whole life. So really, now I guess what, 24 years having been on a pump. Um, and the first pump I had was the MiniMed 507C, and it used little watch batteries, and it had a window that you had to pull open to put the reservoir in, and it was definitely not waterproof. And basically, it just sat there, and I had to pretty much do everything. I'll never forget when the first bolus calculator came out, and I didn't have to calculate my doses anymore. And man, just from that, actually, Todd, we go way back. He was the Medtronic rep for me when I was still in college and graduating nursing school and working at Children's Hospital, and he helped me get my very first sensor. And I remember it kind of hung down, and we had to figure out a way to hide it, but that needle was about that long too. So it's amazing at the technology.
Not appropriately named soft sensor. That was
Yeah,
a
it wasn't very
a
soft.
falsehood. It was not soft. And it was
Yeah.
had a little harpoon type device at that point that you put it
So,
on
Yes.
so,
with.
so Todd, sounds like you've been around and you've seen the evolution of insulin pumps. What do you think has been the most significant piece of pump technology, say in the last 10 years?
Well, I think that the first one was a little bit before that, and that's to Jill's point. When the bolus wizard was first introduced in the I guess that was 511, Jill, that we introduced that. Is that right?
Yes.
Um, that was probably the biggest thing up to that point. And then, despite the cumbersome nature of the first CGM, which really they had not planned to bring it to market the way it was, um, it literally was. It was about this big around and had a wire uh, that you kind of you had this whole big thing on you. And but that being said, the ability to see what your sugars were in real time has to be um, the most impactful, if that's a word, thing that we have brought to market. And in terms of the effect it has on the peace of mind, so much of diabetes is how much information do you have to be able to make good decisions, both as a patient and a clinician, as you well know. You know, if a patient comes in and hasn't checked their blood sugar, you can't do anything for them. And for a patient to be able to respond to high blood sugars or low blood sugars in real time, I think that was the biggest game changer that we've had, and that was really about 10 years ago, a little bit more than that, when 522 came to market, 522, 722, and then when Revel came to market and we had a suspend feature with that, I think that was the next step. And now where we are today, as Jill kind of described, that the pumps are responding in real time to either rising or falling glucose. That first step in being able just to see what glucose is in real time, I think has allowed us to kind of automate these things that way. And that, so to me, that was the biggest breakthrough really since pumps came along.
Okay. Yeah. So at one point, we didn't have finger sticks. We didn't have the technology, right?
Right.
So you would go to your doctor's office, they draw blood, you'd go home, and if you saw them on Monday, maybe on Friday, they'd call, they'll let you know, hey, your blood sugar was whatever in the office.
Right.
And then we had where patients were at home. They would dip the urine, and based on the color of the urine, then they would, that was how we told what the blood sugar was. And then we went to where everybody had a meter at home. Okay.
Right.
And now everyone probably on internet, on TV, they're seeing continuous glucose monitor. They're hearing that phrase, continuous glucose monitor.
Oh yeah.
What is that? What is that, Jill? What does it do, and why is that so exciting for everyone?
Well, I think just like what Todd said, being able to literally, rather than having to stick a finger every single time, and even, yeah, we consider that being spoiled from what you were just talking about from way back. But being able to just push a button and know what I am, um, it's game changing. And then, of course, knowing and having that peace of mind that it's not only if I look at it, but even if I'm not paying attention or not looking at it, that I will be alerted at whatever level I set. So if it was my 4-year-old son, I would obviously set to have that alert a lot sooner than myself. So just being able to customize that to whatever the patient's needs are is, to me, just I couldn't live without it. I truly couldn't. And so I'm thankful that now, based on insurance coverage and just accessibility for most all patients, whether type 1 or type 2, that is becoming more and more something that they'll be able to access.
Awesome. And so Todd, with the advent of continuous glucose monitoring technology, there seems to be now this shift. So the A1C has been kind of the gold standard. Everybody's been talking A1C, A1C, A1C. Everybody's come up with criteria for where you need to be, less than 7, depending on which organization you follow, or less than 6.5. Now we're starting to hear about time in range. Is that a consequence of continuous monitoring technology? Is that a good thing? Is it a bad thing? What do you think?
Well, I think that for the longest time, I've known over the years, just because I've been around diabetes so long doing this job, that you may know Joe Teague down in Birmingham. He was always trying to come up with formulas for determining what someone's glucose variability was. And a guy named Earl Hirsch has done a number of studies looking at that and seeing and he's out in Washington State, seeing that glucose variability is oftentimes a better indicator of, potentially a better indicator of what is known as endothelial dysfunction and some of the things that are causing you to have sticky arteries and to get these clogs and to have these micro and macrovascular problems, and said that, A1C alone doesn't tell us that, but variability along with an A1C can give us a really good picture of what's going on with someone. And when you consider that a person could have a 7 A1C, but they could be passing through normal occasionally, but living really low and really high, but just the average being what it is, you can understand that there's patients who are at potentially even at very high risk for both ends of the spectrum, DKA on one end or severe hypoglycemia, which is also life-threatening on the other end, but still have a good A1C. And so clinicians such as yourself, who were not married to the A1C, were always talking to patients about what their glucose looked like as much as possible. Time and range has given us the ability to see in a state of basically what we would call euglycemia or normal blood sugars, to know between 70 and 180. If you're living in that little narrow range there, that gives us a much better idea as to the overall health of the patient than just that raw number with the A1C. You don't throw away the A1C because we have too much clinical data to say this is an important thing. But we also know that there are things that put patients at risk that make us say the A1C is fine, but if you're 6.5 and you are living in the 40s and 50s, we need your A1C to go up potentially until we can. And so time and range gives us a way of really looking at that. And so we're shooting for, 70, 75% time and range or higher for patients. And really with the new technology, we're able to see patients living in the 90%, in that range, and avoiding those extremes that can put the patient at such acute risk. So I think that A1C definitely gives us a good long-term view of what overall control has been. Given a patient time and range lets them know they're living the right kind of life in attaining that A1C, and prevents them from having such high risks on those extremes, if that makes sense.
Okay, sure. So we went from backpack to small device. We went from using urine to check blood sugars to finger sticks to continuous glucose monitoring. And so closed loop. Okay.
Mhm.
Some people watching this may not even know what that phrase means. Can one of you explain to me what is closed loop? What does it have the potential to do for us? And what have we seen now that we have, I think there are two on the market, a hybrid closed loop actually,
Right.
that are being used.
I'll let Jill speak to that because she's kind of been through the ringer on wearing all the pumps and everything, and now it's getting to use one of those hybrid closed loops.
Sure.
So I'll let her talk about that.
Yeah, sure. So when you think of closed loop, I mean, that's just what we think of, those of us who have diabetes or have family members who have diabetes, so long for the day that you can basically just slap it on and you're done and you just go about life and it just does everything for you. So that's closed loop, where the pump and the sensor are continuously working together to just ultimately manage the patient's diabetes for them. And not having to think about what they're eating, not having to do anything really other than, I guess, change the infusion set and the sensor at whatever given time eventually that technology would allow. So that's down the line, for sure, hoping to see that some of the studies that are taking place now are ultimately pretty much closed loop, which is so exciting to know that the actual studies are being conducted. So I can't say a whole lot, but I can say look it up. But I would say just know it's exciting.
Wow. What amazing information and what a conversation we've been having with Jill and Todd. But we've got to end it here for now, guys. There's so much more that we talk about. Be sure to catch part 2 of our conversation where we answer the question, what's next in the management of diabetes? And hear Jill's personal message to people who are struggling with diabetes. Hey guys, if you are getting some value from our YouTube channel, please go ahead and hit the subscribe button, hit the bell so that you'll be able to get announcements when we do new videos. Also, in the comments, drop us a line. or in our email, let us know what are some topics that you want us to cover. What are some things that you want to hear about, some things that interest you, and we'll be sure to include those in our videos. Thank you for watching. I hope you learned something from listening to Todd, listening to Jill as we discuss diabetes and some of the technology and changes that have happened in the treatment and management of diabetes. Thank you for joining us. This is Dr. Dwain Woode from Diabetes and Endocrine Wellness Center and The Light Away, educating the public for a better you.